afternoon, everyone. I'm Kelly Nagel. I'm the Director of Systems and Performance at the North Dakota Department of Health. And I also need to give credit to Christy Gerard, our Health Equity Director, who had a conflict today. She's actually probably giving about the same exact presentation to an interim committee right now. So I am filling in for her and sharing information on behalf of her. And then I have added some information about the communities and local public health units that I work with. And so I will be describing the difference between health equity and health equality, the social determinants of health, health and all policies, and then having some discussion of what public health is doing to address the social determinants of health and health equity. And that's when I'm going to turn it over to our local partners, Renee Mock at Bismarck-Burley Public Health. And then she has Commissioner Guy with her as well. So we're going to be hearing some local stories. I'm going to start with some definitions. What is health equity, inequity, and health disparities? Health inequities are the differences in health status between more socially advantaged and less socially advantaged groups. And it's caused by systemic differences in social conditions and processes. And then we have health equity, which is when every person has the opportunity to attain his or her full potential, health potential, and that no one is disadvantaged from achieving this potential because of a social position or other social determined circumstance. And then we have health disparities, which are population-based differences in health outcomes. So an example of this would be breast cancer rates, which are higher among women than men. And then although disparities is often interpreted to mean racial or ethnic disparities, there are many dimensions of disparities that exist. And so it isn't just race-based. Attaining health equity is a familiar goal to public health practitioners. Public health practitioners have traditionally served the most vulnerable and filled gaps, or they provided services to those who would otherwise gone without. And now that there is more focus and greater understanding on the root causes, or which I'm going to refer to as the social determinants of health, on health inequities, public health is even doing more. And so as I mentioned, I'm going to turn it over to Renee Mock later, and she'll kind of talk about what local public health is doing to address that. So in order for community leaders, practitioners, and others to eliminate the disparities, we have to be aware and address the social determinants of health. And remember that health inequities are not just the result of race, and especially in North Dakota, and you're going to hear me reiterate that quite often throughout this presentation. So what are the social determinants of health? The World Health Organization defines social determinants of health as circumstances in which people are born, grow up, live, work, and age. And it's the systems that are put in place that we deal with illness. So these circumstances have tremendous effects on one's health, and they can affect anyone regardless of age, race, and ethnicity. So for example, in the U.S. each year, there's 1.5 million individuals that experience homelessness. There's 3.6 million people who cannot access medical care due to lack of transportation. There's 40 million people that face hunger and 11.8% of households that are food insecure. So imagine how those challenges can impact one's health. So here in North Dakota, there are inequities and disparities. There is an estimated 542 individuals that experienced homelessness in 2018. There are 22.8% of households that are cost burdened, 8% of North Dakotans that are uninsured, 54,930 North Dakotans that face hunger, and out of those, 16,130 are children. And there's 9% of households that are food insecure. And this is just a point to keep in mind that a household is considered housing cost burdened when 30% or more of its monthly gross income is dedicated to housing. So individuals and families whose housing costs exceed that, they're less able to afford, and they struggle to pay for other basic needs. So to reiterate why the social determinants of health are important is because they have a tremendous effect on an individual's health regardless of age, race, or ethnicity, and only 20% of an individual's health is tied to clinical care, which includes access to and quality of healthcare services, while 80% of an individual's health is tied to their physical environment, or the social determinants of health, which is where we live, work, and play, and then the behavioral factors, which include exercising and smoking as an example. And this is a table or a graphic that shows what the social determinants of health are. Each of these areas on this slide represents struggles many in our communities face, and each is also a barrier to good health. So to improve people's health and well-being, we need to consider these factors and address the social determinants of health, which include housing, food, education, transportation, violence, social support, employment, and health behaviors. So now that we know that the social determinants have a bigger impact on a person's health than clinical care, we must support practices that address these key issues as a part of successful population health strategy. And on this slide, there is a link that's embedded to a video which was actually created by CAT Communications and the Health Department that talks about the social determinants of health and what the difference is between health equity and health equality. And it's important to know that there are differences between the two. Equality is more providing the same resources, the same considerations, the same opportunities. And equitable is having opportunities that meet each individual's circumstances or needs. So providing them equitable opportunities. And so meet Bob. Bob lives in a house in Minot. Whenever Bob has a medical emergency, it takes him no more than 5 minutes to get to the hospital. This is Sharon. Sharon lives on a farm in a small town called Max. The nearest hospital to her is also in Minot, which is 30 miles away. Sharon and Bob have the same doctor that treats them both equally. This is called equality. Equity, on the other hand, is different. Health equity is giving everyone the same opportunity to the highest level of health care. That meets their needs. While a doctor may treat someone from a small town the same way they treat someone from a big city, that doesn't mean these people have the same access to the same healthcare opportunities. If Bob has a health emergency, he has a much better chance of getting the highest level of care he needs right when he needs it than Sharon does. The first step to fighting for health equity is to start talking about it. Start the conversation today. Visit ndhealth.gov to learn more. So to reiterate the video that you saw and didn't actually hear, the point of this picture is that they're demonstrating or showing that there are 4 individuals of different heights or circumstances that are attempting to ride a bike. In order to treat them equally, they would be given the same size bike to ride, which is the first line or the top. However, doing so wouldn't necessarily allow each of the individuals to ride a bike. So in order to give them equitable treatment, each person would need to be given a bike that would allow them to ride for whatever their needs are. And that's the picture that's depicted on the bottom there. So that's equity. An approach to address those social determinants of health that we just covered is to apply a health equity lens or consider health in services, policies, practices, and procedures. This is called the health in all policies approach. And the health in all policies, in other words, is a collaborative approach to improve the health of all people by incorporating health considerations into decision-making across sectors and policy areas. And it's an approach to address the social determinants of health, which are the key drivers of health outcomes and health inequities. The Department of Health has been looking through this lens for some time now. Some of the things they've been doing is building stronger partnerships with behavioral health to assure that people with addiction and mental illness have opportunities for physical health. We've been expanding family planning services to individuals who are incarcerated, partnering with community leaders and implementing blue zones, providing nursing services in rural schools, and much more. So the goal of health in all policies is to ensure that all decision makers are informed about the health, equity, and sustainability consequences of various policy options during the policy development process. So I think that's key to keep in mind is that health needs to be considered at the very front, not after the policies have been developed and implemented, and then you determine the impact. So this health in all policies approach engages diverse governmental partners and stakeholders to work together to improve health and simultaneously advance other goals, such as promoting job creations and economic stability, transportation access and mobility, and many others. This next slide too also has a link that is embedded. However, I think that's something that you might need to watch on your own. It describes the elements of a healthy community, and it starts with the environment in which we work, live, and play. And the elements that they are describing or include in this video are clean air and water, tobacco-free businesses, safe community, healthy schools, affordable homes, and good-paying jobs. And so the video demonstrates that healthy environments are created through policies, as we just mentioned about the health and all policy approach. And it summarizes or focuses and points out that the health and all policies approach brings agencies across a common goal. So intersecting with different agencies to address a common goal. And that YouTube video is from changelabsolutions.com. So in summary, before I turn it over, these are just some elements that describe what an unhealthy community would look like and what a healthy community with health, what a community with health equity would look like and one without health equity would look like. So the one without is the unhealthiest community. It's deteriorating. There's infant mortality. There's increase in chronic disease, shortened life expectancy. There's a lack of civic engagement, behavioral health challenges, and occupational hazards. And then if there is health equity, it's the healthiest community. There's thriving and improved birth outcomes. There's a decrease in chronic disease, longer lifespan, civic engagement, behavioral health opportunities, and increased workforce development prospects. And I wanted you all to be aware of a recognition and funding opportunity to the Robert Wood Johnson Foundation. It's the RWJF Culture of Health Prize, which recognizes communities that have come together around a commitment to health, opportunity, equity through collaboration and inclusion. The prize honors those communities that are working to give everyone the opportunity to live well, including residents that are often left behind. A culture of health recognizes that where we live, our access to affordable and stable homes, quality schools, reliable transportation, all make a difference in how we thrive and how we and our health status. So the application period is usually open, and then I think the deadline is in November, so it's kind of a rolling application. And so for any of the communities that are working to address the health inequities, this is a great opportunity for you not only to be recognized nationally, but you could also receive a $25,000 prize that you could further invest into that improvement that you made. So now I'm going to turn it over to Renee Mock, the Bismarck-Burley Public Health Administrator, and she can tell you a little bit about what local public health is doing.
Perfect. Thank you, Kelly. That sounds like a great resource that you mentioned, and I'm going to make sure to send out a link to that in a follow-up email, and then I'll also send out a link to the YouTube video that you included in here. So thank you for sharing that. Renee, I'm going to turn it over to you.
So I guess I'll just introduce myself. My name is Renee Mock. I am the Director for Bismarck-Burley Public Health. And thank you for the opportunity to speak to the group today. I'm going to talk a little bit about what we're doing at Bismarck-Burley Public Health to advance health equity through some of the services we have. It should be up on everybody's screen, I believe, right?
Yep, looks like it's
okay. Perfect. So some of the objectives today, I will be defining local public health, what we do, who we are, describe some of our strategies that we've used to advance health in Bismarck and Burley County, and then also share what you can do to advance health equity in your communities. So just to start off about what is local public health, population health-based health services kind of sums up local public health. We look at the health of the entire population rather than individual incidences and individual health care. And so that is our main focus. There are 28 local public health units across the state of North Dakota, and they are organized into single or multi-county health districts, city-county health departments, or city-county health districts. So it just kind of depends on the governing structure, which area the local public healths fall into. And our department is actually a department of the city of Bismarck, and we contract with Burleigh County for local public health services. So our entire service area covers all of Burleigh County, both urban and rural. And this is a map of the local public health units across the state of North Dakota. You can see that Burleigh, Cass, and Grand Forks are set up in similar format as a city county health department. And then on the western side of the state, it's a lot more rural area where we have multi-county health districts, and then several mixed of single county health departments, and then also single county health districts. So that kind of gives you an idea about the state breakdown. A big part of what we do is a community health needs assessment, and that's a way for us to kind of get a survey and a lay of the land on what the needs are in our community. Burleigh and Morton counties completed the last health needs assessment in 2018, and we've been doing those since 2012 with the local hospitals. It's been a collaborative effort between local public health, Sanford, and St. Alexius, CHI St. Alexius Health, to assess both Burleigh and Morton counties, as those are the main service areas. Okay, in our survey, we looked at economic well-being and did an assessment on that with a level of concern ranging from 1 to 5, where 1 is no attention needed and 5 is critical attention needed. So we did a random survey and found that our highest rated economic well-being concerns were homelessness at 4.44, housing accepting people with chemical dependency, mental health and criminal history issues came in at 4.33, and availability of affordable housing came in at 3.87. And usually anything over 3.5 is something that we should consider as concerning for our area. So these are areas that we are trying to focus on as they are well over that 3.5 score. So we did our needs assessment, and now what? Our results were shared with our community health stakeholders and policymakers. We had a community health stakeholders meeting where the results of the survey were shared, and we broke out into groups to talk about some of the needs and priorities. And then this is used to develop a department strategic plan, and that has filtered in through our City of Bismarck strategic plan as well. Some of the goals and objectives from our department fit perfectly into the city's overall plan. We also presented to the City Board of Health and engaged commissioners in the incorporation of health in all policies. And that's where Commissioner Geiss came in and has been actively involved with local public health and trying to move some of these efforts forward. Most recently, I wanted to speak from some of our experience that we've had here locally. We've come upon minimum rental housing standards. This was an issue that was brought to Commissioner Geiss by community members. And in talking about the actual structure itself was building inspections, but then the health piece came in several different ways following that. This is an example of mold that was found in a rental property along windows and walls. And the bottom two photos are actual photos from our environmental health department when they did an on-site assessment. And the top two photos are from photos from another area. But this is the types of concerns that we have relating to health when it comes to rental properties. So in talking with building and inspections and their structural issues that they have, the health aspect of this rental housing standards came into play. Another issue that we've seen along with the rental housing is bed bugs and the ability to control some of the population that they have in some rental establishments. You can see here with the bed bugs around the electrical outlets, this is a really bad infestation actually. They like to be around the warmth, so you can kind of see the evidence of that there. And then there's also the bedbug mattress infestation, and this is an ongoing issue. So if someone is living in a rental facility and the landlord is not taking care of the bed bugs, not getting rid of them, not calling in pest control, this becomes a health issue and is another thing that we're trying to address through our ordinance through minimum rental housing standards. So that's where I will bring it to Commissioner Guy. She has been our champion for public health. She's our portfolio holder and has been for the last several years. In addition to her experience working with us, she's also in her day job the operations director for Community Works North Dakota. So I will turn it over to Nancy and have her give you some information on her knowledge.
Good afternoon. I am really excited to be here. It's not often I run into a bunch of people who are really, really interested in this subject. A lot of people kind of look at you funny when you bring it up because it is kind of a new concept, I think, in our local governments across the state. So first of all, I'll tell you a little bit about my day job at Community Works North Dakota. We are one of 3 organizations that make up the Lewis and Clark Development Group. And Community Works concentrates on financing single and multi-family housing for low and middle income families. Community Works is the only NeighborWorks America organization in the state. And NeighborWorks America is a congressionally chartered organization that is used to disseminate federal community development funding throughout the country. So, you know, some states have 4 or 5 NeighborWorks organizations, but North Dakota has only 1. So we do operate statewide. Our other 2 organizations concentrate on economic development in Region 7, which would be 10 counties, and then we do have some programming that is statewide. And the 3 organizations work really well with each other because there are times when the commercial financing, economic development side of things can step in and help us out with some of our multifamily financing. And there are times when our Community Works side of things can help the other 2 organizations. So it's a really good fit. We just celebrated the 50th anniversary of our first organization, which is the Lewis and Clark Regional Development Council. And our collective impact over the first 50 years has been 3,600 jobs created or maintained, 2,800 single or multifamily housing units financed, and 143 rental units owned or managed. So that actually adds up to about $640 million worth of impact and investment across the state. So we're pretty proud of that. We're a small but mighty group. So if we go back to Community Works, our mission up until this last year has really been all about helping low and middle income families buy a home. And sometimes that's tough to do in rural areas. And then we got into financing multifamily low income housing. And as a nonprofit, we're actually able to bring low income tax credits to the table, or federal home funding, or federal home loan bank grants and loans, and other kinds of low interest financing, so that we actually buy down the cost of the project, which enables the owner to keep the rent low and still have a good reserve for maintaining the building over time. And this has been really critical in rural areas where low-income housing is aging out of the USDA Rural Development Subsidized Rent Program. We had a pilot program addressing that, and the current administration suspended that, and so we're fighting a headwind on that side of things. So then we thought, well, if we can't preserve that housing, how else can we preserve housing around the state? Bismarck lost its only emergency homeless shelter, and so in our efforts to find a provider and find a location, the idea, somebody pitched the idea to my boss, I think it was one of our county commissioners, that maybe Community Works could help out by financing the property, and that way the nonprofit shelter provider could quickly open a shelter and not have to wait for a capital campaign. So we just closed on a building with Missouri Slope Area United Way here in Bismarck, and we'll be building a $2 million addition onto that building, and that will house the new emergency shelter serving men, women, and families. And then United Way will move some of their existing program into the original side of the building. So that was kind of a departure from our usual mission, but our board really embraced it. And if we can duplicate this situation in other communities, it might be really helpful in other communities like Williston or Dickinson, Devil's Lake, Minot, where they don't have this kind of shelter, but they really need it. So we're pretty excited about that concept. So another housing preservation partnership we have going right now is with Lutheran Social Services. Ruth Meyer's Hospitality House had bought a former nursing home in Bismarck, and they were successful in renovating most of it into low-income housing. And they ran into financial difficulties and lost the building. So we have partnered with Lutheran Social Services, who has a proven property management track record with low-income housing. And we're finishing the renovations on that building. And when it's all done, there will be 106 units of low-income housing that's just desperately needed in Bismarck. And LSS, if they're able to get a zoning change, will move their offices to that building as well. So we're pretty excited about the new direction that we're going, and it's been interesting to see how my day job sort of spills over into the city commission. Renee had talked about the minimum rental standards. And those came about because I was hearing anecdotal stories at our local homeless coalition meetings. And they really upset me because it was stories about families who were considered high-risk renters because, there might have been an incarceration history there, or poor credit, or they've been evicted somewhere else in the past. There was something that in their current or past history that made them, in the eyes of a landlord, a high-risk tenant. So that typically means that you pay more rent and you get less rental property. Let's just say that it's not the fanciest place in town. So not only is it not the fanciest place in town, I was hearing stories about like holes in the floor that were covered up with carpeting, windows and doors that leaked cold air badly, like you could see daylight around them, issues with water and sewer, bedbug infestations, and landlords just unwilling to fix those issues, but very willing to charge extra rent, excuse me, to these families. So we talked about some minimum rental standards. And those, we found that we didn't have any in our ordinance, and I thought that was real strange because most communities do have something. Well, it turns out in the early 2000s, when we adopted the International Building Code, we removed a huge chunk of our building inspection ordinances, and we believe now that those existing standards were inadvertently repealed, or we mistakenly thought the International Building Code would replace those minimum standards ordinances, and they do not. So at the moment we're in the midst of coming up with new standards and making sure that they also apply to mobile homes in Bismarck, and then also some minimum standards for owner-occupied property as well. So I'll be really glad when that's in place. We'll have to make sure that we meet with the stakeholders that are affected, meaning the landlords and mobile home park owners. And I've already met with the Homeless Coalition with a draft, and they were very supportive of it. But this is a really good example of health in all policies. You know, we need to kind of have a framework of questions we ask ourselves as we either update our ordinances or we create new ones. You know, are we going to inadvertently have a disparate effect on a group that we don't intend to? Or are we going to have some bad unintended consequences in some other area of the city? So Renee and I are going to sit down here after our budget is put to bed for the year and kind of take a look at how we might want to work this into the city commission's regular, I guess their regular way of doing business, and you know, how far we want to take this. I suspect we'll need to do it in stages because it can be kind of overwhelming when you read the manual. But I also would like us to get to a point in terms of housing and health where some of the rental policies are not barriers to affordable housing. So, you know, can we come up with a framework for considering incarceration, history, and that kind of thing, so that we're just not punishing people for their poverty? It becomes a really vicious circle. And I think housing is, I mean, all of the social determinants of health are important, but housing is really pretty basic because it's hard to keep a job when you don't have a home. It's hard to manage a chronic illness when you have nowhere to live. It's really pretty central to all those things. So I'd like to make sure that Bismarck does a better job in making sure that everybody has an opportunity to live a dignified life. So are there any questions?
So Renee showed a map of all the public health units across the state, and I noticed that there are some that the multi-county units have a much larger geographic area to cover than ones that are multi-county, or the ones that are single county, or even I think there were some that were smaller than that. Do you know if there's disparities in the resources and services that are available across the state based on the size of the public health unit? And why is there a difference in the size of the area?
Well, the answer to your question, yes, most definitely there is disparities, especially in the rural single counties. And the differences in size is how the governing body, city or county commissioners, decided to adopt or form their local public health structure. As Renee had mentioned, they can either be districts or departments, and in the West was where North Dakota Local Public Health was first established. And when you saw on the map all the yellow areas, all of them decided at that time to form as a regional or a multi-county district health unit. Where those are usually considered larger health units. Yes, they have a larger geographical area to cover, but they also have more staffing. Usually they have a satellite clinic in each of the counties. However, those satellite clinics provide minimum services. Most of the time it's like public health nursing, school nursing, immunizations, and then they usually have more expertise within their health unit jurisdiction. So they'll have the environmental health practitioner, they would have the emergency preparedness coordinator, the nutritionist or dietitian, where the single county, the smaller ones have 1 to 3 staff, and usually it's a public health nurse and an administrator. So they really count on their neighboring or the larger health units to provide some of the subject matter expertise. They are working in what we call regional public health networks, so some of that expertise and services can be shared amongst those that don't have that staffing. So yes, most definitely there is disparities in the rural single county areas.
Okay, thank you for explaining that. Yeah, so the question I had for you, besides housing, which has a very clear connection with health, what other policy areas you are looking at in Bismarck to integrate a health and all policies approach? And as I say this, I also see that Kim Lee is on. So Kim, if there's anything that you feel like sharing, speaking up about right now, please feel free as well.
So there are some things that Renee has been doing already, and I'll have her talk about that. But then there was a couple of things I also wanted to mention, and that is that the last legislative session is probably going to help us out a lot with funding for social detox services, which is something we felt that we were going to have to start up from scratch. And it turns out that there is now more funding for our West Central Human Services, and I think all of the human service providers across the state to open up their social detox to the general public and not just their clients. And then also, we'll be looking at a way to provide low barrier sheltering for our homeless population. And the city will, it appears that the city will be participating in funding our new emergency shelter here in our next budget. So these are all new directions for the city to be taking in that area or in the health area. And I'll have Renee describe some of her current initiatives.
Yep. So another initiative that we are looking at is responsible beverage server training. Right now, that is not as part of our ordinance to require liquor establishments to have that type of training. And so it would benefit obviously the health of those involved, and also the safety of police department would also be involved with that. But we're learning about that right now and hoping to work with Commissioner Guy to see where that can go as far as ordinance changes.
Oh, I was also going to mention that Renee and her environmental health staff have been offering food service safety training, and to just an incredible response rate to offering those classes. They add extra sections every time they offer it, and it seems to be really popular. So, we were excited to see that as well. Go ahead, Ben.
Yeah, hey, Emily and others. This is Ben Arith, and we've got Kim Lee and Jenny Wolmuth, all from Bismarck Community Development Department. Just a couple other things to add that we're currently engaged with that has some relation to health and all policies. One is our local roadway design standards that we're working on in concert with our engineering department, and actually the development community in Bismarck-Mandan actually help probably kickstart this conversation, but in looking at it from a kind of a community design perspective, we're looking at narrowing our residential roadway design standards from what's now, roughly 40 feet from curb face to curb face to narrower options, which has an influence. There's been a variety of research that states that the way the roadway is designed, in other words, the narrower a roadway cross section, that has an influence on the speed of how quickly vehicles are traveling up and down the street, which also has an impact on human health and safety when folks are walking in their neighborhoods and trying to cross those streets. So that's certainly one effort that's ongoing, and another that one might not necessarily think immediately that would have an impact, but Jenny's actually kind of leading an effort to reevaluate our parking ordinance for the city of Bismarck. We're going to be looking at a whole-scale rewrite there. Parking is one of those issues that kind of cross-cuts across a lot of issues within the community, and one of those is sometimes it's a barrier to providing more affordable types of housing because of the minimum parking requirements that we have and that have to be met. So it's an opportunity for us to evaluate for multifamily and more medium density housing, and especially for infill and redevelopment projects, how we may make those more realistic and I guess create more opportunities for more different types of housing. So those are just a couple additional things beyond what Commissioner Guy and Renee had mentioned.
Thanks, Ben. I'm really glad that you mentioned the connection between community design and transportation. I think if we can build communities in a way that encourages people to use active transportation, whether it's walking, biking, pogo sticking, skateboarding, those are all ways to increase physical activity. And then some of the things that you mentioned, there are a lot of design tactics that can allow us to slow traffic. And not only will that make people feel more comfortable walking or biking, but it can also make those streets a lot safer and decrease accidents and mortality too. And the parking ordinance one is an interesting point. That's a hot topic right now around the state, and I'm glad that you made the connection between parking requirements and affordable housing. One other health-related issue that comes up a lot when we have conversations with Main Street communities is access to food, whether it's a grocery store or a cafe or restaurant. And this is kind of a big picture question, so I'm going to open it up to Kelly, Renee, Nancy, anyone from the Bismarck team, or anybody else who's on the line. But do you know of any policies statewide in any community or in other states that might seek to address some of the lack of access to food that we have in our rural communities?
This is Renee. I know our dietitian, Katie Jonke, is also listening, and she is kind of working on local foods and making them more available, healthy food more available in our area. So Katie, if you're listening, if you would like to kind of talk about some of the things you're doing.
All right, so as Renee mentioned, yeah, one of the areas I work in is through local foods. And so a couple opportunities that come up is the community orchard that we have access to in the community. And that's something that we are, as the orchard is slowly growing, we are slowly trying to share that with the community and create access opportunities for different groups. And one great partnership we have with the orchard is with the Police Youth Bureau. They are our volunteer workers that come out and help weed. And also we connect them with fresh food that a lot of them have not ever seen a raspberry grow off a bush or have been part of that. And so it's a great opportunity to connect with them and kind of broaden their horizon too. And then I work with the local farmers market, Bismarck, and we work on a lot of different areas to increase that access. And that's one of the areas that Bismarck focuses on as well, is how can they do more. And they do accept SNAP, which is a huge piece to the puzzle. And so just really trying to get more and more people to the market, more and more vendors as well. And then I do some work with, or am in the process of doing some work with food pantries and just creating that access to healthier food options throughout the.
Emily, this is Kelly. If I could add to, I know the health department has been working to create state law or policy to better regulate some of the farmers markets to assure that the foods that are purchased there are safe. So there's that type of policy, and then just making sure that in those regulation policies that it doesn't decrease the access to the healthy foods. The other thing that I know other states are doing is they have, or even cities have adopted ordinances for their farmers markets to require the vendors to accept like food stamps and WIC benefits. So that's just a couple things that came top of my head.
Thank you, Kelly and Katie. And Taylor, I don't want to put you on the spot, but I just looked at the list of people on the call and I noticed you're on. Is there anything that you'd like to add about food access in North Dakota communities while we're on the topic?
Hey, thanks for the invitation to chat a little bit. My name is Taylor Sievertson. I am the Health Impact Manager for the Great Plains Food Bank. So my role really is to address hunger as a health crisis and understand how our sort of health care providers and entities and organizations can work hand in hand with the Charitable Feeding Network. One of the things I read about recently that this conversation was just kind of sparked in my mind is particularly regarding rural grocery stores. I know that some communities are having difficulty keeping their rural grocery stores standing, so to speak, because of the presence of dollar stores. And, dollar stores are a inexpensive way for families to get sometimes shelf-stable, potentially, foods that aren't quite as healthy, and they also take customers away from the local grocery stores, farmers markets, or other spaces, because if someone has 15 SNAP dollars to spend and they're trying to make their limited resources stretch, potentially in some cases folks are making choices to help their food dollars stretch a little bit further. And so I know there's been some recent conversation about the proximity of dollar stores to rural grocery stores, or how many there can be in certain size communities. And I know that I don't know if it's happening anywhere in North Dakota, but I know nationwide that's a conversation, and how to keep those rural grocery stores afloat and being able to provide the healthiest produce and fresh items that dollar stores often don't provide. That's just one thing I'd like to add in terms of policies and how some communities are addressing food and food access.
Thank you, Taylor. That's a hot topic in a lot of the communities that are involved in the Main Street Initiative as well. And it's really unfortunate to see the rural grocery stores struggling. Well, with that, I just want to thank everybody for their time today. And special thanks to Renee, Nancy, and Kelly for putting together the presentations and then taking the time to talk about what they're working on. And also want to thank the City of Bismarck, Katie, and Taylor for talking about health and all policies from the approaches that you're working on.